Hi, we're Group 4-5. Our program is Relief. Our program goal is to reduce the prevalence and incidence rate of marasmus and kwashiorkor in India. Our priority population are children under the age of 5 and/or pregnant breastfeeding mothers. For our program evaluation process, we will be answering the following questions. 1. What percentage of our target population attended the nutritional classes? 2. What percentage of our target population attended the food distributions? 3. Is there a difference between those who attended our events and those who didn't? And 4. Can the risk of malnutrition diseases be predicted by the amount of knowledge on the issue, hence our nutritional classes, access to necessary resources such as our food distributions, and community involvement? Our program followed the health belief model. Our impact outcome was to get as many families as possible to attend our nutritional classes and our food distributions. Our health outcome was to decrease the prevalence and incidence rate of marasmus and kwashiorkor.
Our research evaluation design is a non-experimental pre-test post-test design. This can be demonstrated as Observation 1, including pre-test health assessments using BMI, blood tests, visual body exams, and surveys measuring their knowledge on nutrition, the intervention of our services, and Observation 2, a post-test of health assessments and surveys. We don't have a control or comparison group because it would be unethical to deny services to a portion of the community suffering from these diseases.
The approach we implemented in choosing our participants was the convenience sampling method. Participants who were selected for this program within the high-risk locations of India had to meet the specific criterion to qualify for the intervention. This sample population included children who were 5 years old and under, since this is the age group of children affected by the diseases marasmus and kwashiorkor, as well as pregnant and breastfeeding mothers, since malnourishment in this population would in turn produce undernourished children. Our program relied upon two independent variables that we anticipated would influence the desired outcome within our target population. The first variable is conveniently located food distribution centers that would mitigate the prevalence of malnutrition-related diseases. And our second variable, implementing nutritional classes, would impart behavioral skills to gain and maintain the proper diet within our target population. Consequently, these steps lead us to the dependent variable of decreased incidence and prevalence rates of malnutrition-related diseases, kwashiorkor, and marasmus.
Based on our variables, we will measure our data through nominal measurement, in which our sample population, based on each participant's results, will be assigned into numbered categories. For example, each participant would either fall into Category 1, equaling without the disease, meaning either at risk of malnutrition or experiencing malnutrition, or Category 2, equaling with the disease, either kwashiorkor or marasmus.
Based on the data that we have, we are using a bivariate analysis to discuss the result of our intervention. Because there are two nominal variables involved, we analyze these two variables simultaneously and explain the relationship between them. Through the bivariate analysis, we try to find out the answer of the evaluation questions. We state the null hypothesis and the alternative hypothesis. The null hypothesis is that there is no difference between the effect of the nutritional classes and the food distribution. The alternative hypothesis is that there is difference between the effect of nutritional classes and the food distribution. Based on the data analysis result, we can tell that there is difference between those who attended and those who did not attend.
Based on our nominal variables, a chi-square test of statistical significance can be used to test the null hypothesis that there is no difference in the success of the two groups.
Our data, as illustrated by Graph 1, reveals the relationship between change in BMI prior to intervention and following. The objective was to have 50 or more % of participants utilize both food distribution and education classes as a means to better their health status. We used BMI as an overall indicator of health status because it's easily calculated. The green bars illustrate participants who experienced an increase in BMI as a result of the utilization of all resources provided by our program. This would include education classes and food distribution. The yellow bar illustrates a participant who utilized food distribution but did not participate in education classes. Their post-BMI indicated little to no change. The red bar, however, illustrates an individual who participated in none of the available resources offered by our program and has experienced a decline in BMI over the course of our intervention. 100% of our participants had previously been diagnosed with kwashiorkor and marasmus disease. This requirement was set in place so that we could more effectively monitor the success of our intervention. Graph 2 illustrates the rate of participants who no longer suffer from both diseases as a result of our program. Our program established an 80% success rate of eliminating both kwashiorkor and marasmus disease in participants who were involved in our intervention.
Based on our results, there is evidence to support that our interventions of nutritional classes and food distribution can have a positive impact on reducing marasmus and kwashiorkor in the target population. BMI improved when either of the interventions was used, and even greater improvement was observed when both interventions were utilized together. Limitations of our evaluation show that while both interventions may improve target population BMI, more research is required to determine which of the two interventions is the most effective. Improvements need to be made to community outreach and involvement to identify and address barriers that are preventing our target populations from utilizing our interventions.